So I'd like to thank Bill and Doug and the other Bill as well for this wonderful evening in honor of their wife and mother, Mary. And also thank you to everyone who has come here tonight to hear more about the research in neuro-oncology that we do at MGH. I'm a neuro-oncologist with a busy clinical practice, but I also have an imaging research lab that we're really trying to treat patients with brain tumors and learn more about the disease. So I could talk for a long time about it, but I'll try to be more brief and focused because this is really my passion, and I know you're all getting up to dessert and more drinks, but feel free to interrupt me and ask questions as we go along. But I'm very excited to share what we're doing with all of you. And as Bill was saying, proceeds from the walk and this dinner are really designated to support our brain cancer research fund at MGH. So let me give you a little bit more background about who we are and what we do. So MGH is the largest hospital-based research institution in the world, and it's unique in Boston in the high caliber of its faculty. I'm a little bit biased, but I think all faculty are wonderful, phenomenal people. And the number of scientific discoveries and milestones that have come out of MGH have really been remarkable. What's really nice about MGH is we can provide a lot of comprehensive services for patients. So we take care of patients from head to toe, and that's helpful also in a research setting where research scientists can approach different problems from multiple different levels by fostering different collaborations of people who attack problems with novel ideas and novel ways of thinking and new techniques. As I mentioned, my particular area of specialization is in patients with brain cancer. And unfortunately, there are over 1 million cases of cancer in the United States annually. Unfortunately, there are only about 23,000 of these cases are primary brain cancer. So in the cancer landscape, we really represent a minority of cancer cases. And so our representation on the national scale is really quite small. So we don't have a lot of good support like the Komen Foundation and these other places that are good advocacy groups for patients. Despite this low profile on the national scene, malignant brain tumors are not curable and unfortunately have a very poor prognosis. Unfortunately, the most common primary malignant brain tumor is this glioblastoma subtype, which is really the most aggressive and carries the poorest prognosis. And so I and my colleagues at MGH are really focused on trying to find more effective treatments and hopefully ultimately a cure for a disease that really often strikes people when they're entering retirement and really trying to enjoy their life after working for a long time. We have set up really a multi-pronged approach to studying brain tumors at MGH, which spans preclinical research all the way to human clinical trials. So our preclinical laboratory-based groups looks at tumor cell lines that are derived from patients at the time of surgery. So they take those tumor cells that come directly from patients. They then can implant them into petri dishes and try to grow them up in the lab, or they can implant them into mouse models and see how the tumors grow and change over time and look at very specific genetic mutations that happen in individual patients' tumors. And then they can try to figure out what drugs might target that patient's specific tumor. And then we can take that knowledge that comes from the laboratory back to the human and study it in individual patients through clinical trials. And as was said, we have more than 10 clinical trials for patients with brain tumors, and most of these trials are really trying to target the specific weaknesses that we can identify in patients' tumors. My particular area of research is in advanced imaging of brain tumors, and I apologize for my group at dinner tonight because this will be a little bit redundant from what I was boasting about at dinner. But currently the best way that we have to determine whether or not an individual patient's tumor is responding to a drug is to do brain surgery. So have the neurosurgeon go in, take a piece out, and look at it under the microscope and see how that tumor is responding to the therapy that we're giving to a patient. Now, it's very hard for me to convince my patients to go back for multiple brain surgeries in order to just assess how the tumor is responding. They kind of look at me and say, no, you're not cracking my noggin open again. So what I'm trying to do is to non-invasively study brain tumors serially and longitudinally in patients so that we don't have to do invasive procedures like neurosurgery that clearly carries risk of neurological compromise or side effects. So when I'm talking about imaging, I'm talking about MRI and PET. And MRI and PET scans have really advanced significantly in the last several years. And if you've ever had an MRI scan, you know that it takes about 30 to 40 minutes to do an MRI scan. And the reason it takes such a long time to do is because we're looking at the brain in multiple different ways. Nowadays, with our advanced imaging techniques, we can look at things like blood vessel structure and function. We can even look at tumor cell density and tumor metabolite levels to assess how drug therapies are directly working on an individual patient's tumor. With PET scans, so MGH has one of the few simultaneous MRI PET machines in the country. So a patient goes for one scan and they get both an MRI and a PET. And with MRIs, which traditionally have not had much of a role in brain tumors, we're now able to do a lot more with PET scans than we were in the past. And with PET scans, we can label a lot of different compounds where we can measure tumor oxygenation status, we can look at cell proliferation rate, and we can actually label to see how well drugs get into the brain. One of the biggest challenges that we face in brain tumors is that the brain is a privileged site. And so the brain is protected by this blood-brain barrier. So it does its hardest to keep toxins out of the brain. Chemotherapy is unfortunately a toxin. And so while we want it to get in and kill the tumor, the brain is saying, no, no, stay out. We don't want you to get in, even though it'd be actually beneficial for it to get in. And so really having an understanding of how well our drugs are getting into the brain, so labeling it with a PET tracer, which is what we have done here, we can see how well that drug is getting into the brain. Is it reaching the target that we're thinking it's reaching, and is having the impact on that tumor pathway that we want it to be having? And this can all be done non-invasively without surgery. And so MRI and PET are really ideal tools for us to probe tumor biology on multiple different levels. And it's much easier for me to convince my patient to go for a 30 or 40-minute PET scan than to get admitted to the hospital and have a big incision placed in their head. We've been looking at changes in tumor blood flow. We know that cancer is has a very rich blood supply, and so we're trying to figure out ways of targeting that blood supply. And so what we've actually been able to show, which is a little bit counterintuitive than what you would expect, is that when patients are treated with a drug that targets tumor blood vessels, we've actually shown that if patients have an increase in their tumor blood flow, as shown by the yellow arrows on the second row, that white area represents areas of increased blood flow. Patients can have increased blood flow, or other patients can have no change in their blood flow or a decrease in their blood flow. And so what I've shown with my colleagues is that those patients who actually have an increase in blood flow to their tumor live longer when treated with a drug that targets tumor blood vessels than patients who do not have that response. And we think it's probably because we're actually getting better delivery of chemotherapy to the drug and better delivery of oxygen, which is needed for radiation to be effective. And why this is important to me as a clinician is these changes happen within the first 6 weeks of treatment. And so I can look at a patient and say, oh, look, their blood flow is responding in this way. And if they're not responding in the way that I want them to, then I'm going to change therapy and try to find something that's a little bit more effective for that patient. So again, trying to target our therapies to appropriate patients and figure out what is the correct salvage therapy for patients who are maybe not responding. One of the other things that we have identified is in patients, again, who are treated with these blood vessel targeting drugs, is that there's a particular relapse pattern. So there's a different way that the tumors grow when patients are treated with this class of agents. And so what you see is this increase in white signal on this MRI scan that gradually just and relentlessly increases over time. And we think that this is just the tumor infiltrating into the normal brain and just slowly continuing to grow. So based on this data that we show, I actually launched a study through the Adult Brain Tumor Consortium, which is the next iteration of that North American Brain Tumor Consortium that was mentioned earlier. And so we've just completed that study, and what we did was we combined this blood vessel targeting agent with an anti-invasive agent, really trying to target again this relapse pattern and try to figure out better ways of treating this tumor. So hopefully, I'm still analyzing that data at this point, but hopefully we'll again be able to pick out what are the right therapies for individual patients. One of the other areas that is a very hot topic that we're looking at MGH is looking at tumor hypoxia or lack of oxygenation. And we know that hypoxia is a very remarkable resistance mechanisms that tumors have to treatment. And so we're trying to figure out ways of targeting that tumor hypoxia, to reverse that hypoxia, to try to better fight these tumors. So I think the lessons that we've learned from our research, which really spans preclinical all the way up to clinical studies, should have a significant impact in our ability to help future patients like Mary. And so using both these novel imaging techniques coupled with some of those tissue-based studies that our preclinical colleagues are finding, we hope to really understand what the drivers are behind why these aggressive tumors start and why they respond or fail to respond to particular treatments. And this is really the direction of brain tumor research and cancer in general, is to get a better understanding of what the genetic and molecular underpinnings are of different types of tumors, and really find these patient-specific targeted therapies. And I'm confident that we can do this, and again, with full disclosure that I'm clearly biased about MGH. I think we at MGH are really poised to be at the forefront of this research and really develop and maximize these therapies. So the path of research sometimes feels like Sisyphus. The uncertain economic climate of the last few years has really decreased government support for scientific research, and sequestration has had a particular bad results for researchers. Currently, the National Cancer Institute, which is one of the branches of the NIH, is funding junior investigator protocols at about 9%. So only 9% of applications to the NCI actually get funded. And so this really highlights the need for us as researchers to really seek out other routes in order to support our continued research efforts. And so I think your contributions to honor Mary really will have a significant impact on our ability to complete our goal of finding better treatments for this challenging disease. Every little bit helps us these days. So for example, we use these donations to fund actual experiments that we do in the lab. It actually cost me, I was mentioning at dinner, $4,500 to do one of those MRI PET scans. But it gives me a lot of information about how tumors are responding and what drugs I should be using in patients. And we also use these funds to support our junior investigators also, who are trying to have get a leg up and get their research career started. And oftentimes the junior faculty are the ones who really have these smart, exciting ideas and have the time and energy to really devote to a project and move it along. And giving them support to move that project along is very, very important. And it's a very significant financial undertaking for us to run a lab or a clinical research program. So we very much appreciate your support and do rely on it a lot to make headway in our treating of brain cancer. And as was mentioned, Ashley Bronson is here from the development office, who can provide more information. So thank you again for all of your generous contributions to both time and money, because as I said, your support really does go a long way to helping us to study these brain tumors and ultimately find a cure for what is really a very challenging and devastating disease for families and friends who are faced with this difficult situation. So, I think while we were not able to help Mary as much as we would have liked based on our current knowledge of brain cancer, I hope that this tribute to her will help others in the future. And my commitment to you for all of your generosity is really to make sure that we remember Mary and use her story to continue to inspire us to work harder, because it's really our connection to patients that every day really says, okay, I'm going to work in the lab an extra hour and figure out what's going on. So it really does mean a lot to us for your generosity. So we really do thank you. I'm happy to take any questions.
How early can brain cancer be detected? Our friend did not have that opportunity.
Unfortunately, that is typically the case. People might notice subtle signs, and maybe in retrospect people notice more, but the large majority of patients will have very small signs that eventually they seek medical attention. But that interval tends to be very short between first symptom and diagnosis. A lot of that depends on location in the brain. The brain is all real estate, as I was telling people earlier also, is that if you have a tumor that's sitting in the part of the brain that controls motor function, we're going to discover that tumor sooner than if it's in a non-eloquent part of the brain. So we don't have a good way of detecting it. There's no blood test, there's nothing like that we can detect. We are at MGH, and I didn't mention this because of the interest of time, is we are doing studies where we're looking at circulating tumor cells. And so we do hope that eventually, if we can find a marker in the blood, that we might be able to detect it earlier with a blood test. But it's challenging.
I'm under the impression there's a form of targeted laser surgery that's non-invasive. Is that effective in the brain? And what's the status of other ways of approaching this problem in addition to chemotherapy?
So the laser surgery usually still requires an incision to target the laser to where it's going. But the problem with the laser is the precision of it, and it tends to have it heats up the brain so much that there's more toxicity associated with it. So I think it's an interesting area, and there's a lot of different research in trying to figure out some of those more targeted tools, but they haven't quite made it into prime time yet.
What are some of the leading theories of causation?
It's the $1 million question. It's probably not cell phones, and there are a few that are run in families, but that's the exception rather than the rule. And people have tried to do epidemiologic studies to associate toxin exposure with later development of brain cancer. The problem is the interval between the toxin exposure and the development of the brain tumors can be very long. And when you have somebody who has a new diagnosis of a brain tumor and you say, well, what have you been doing in your life? Where have you been? What have you eaten? The reliability of that data is not very good. So it's hard to do, so we don't know yet.
Tell us a little bit about imaging and whether we should all get our brains imaged.
No.
And why not?
Because the other half of my practice are people who have a little ditzel in their brain that really doesn't mean anything. And they just get followed with MRI scans every year, and the ditzel doesn't change, and they're stuck getting MRIs. And as that annual MRI approaches, they sit there and they start biting their nails, and they say, what's going on in my head? And so the anxiety over that, I think, doesn't make sense. Before you have the MRI, are there any clinical indicators?
If you saw a patient, what would make you think glio right before you got to the MRI?
So most patients will have subtle symptoms, And the symptoms that patients can have can be a wide variety, again, because it depends on where the tumor appears in the brain. It could be from something as simple as changes in personality. It could be memory loss. Some of that, though, is hard to tease out because as people get older, we're all sort of going to the store and saying milk, eggs, and what was that third thing? That's usually not a sign of a tumor, but people will always worry about it. But it tends to be more of a hard symptom: weakness, numbness, seizures. So sometimes if people have seizures that come from a particular part of the brain, they have a smell that's associated with it. And it's classically can be some sort of, sometimes as a metal smell or a gas smell, but sometimes it can be grass or other things. And that just might be a small seizure, and seizures definitely can herald tumors, but not always. And headaches, yes, but not always.
I have a friend whose mother died of what was described as a non-malignant brain tumor back in the 80s, and she was treated at George Washington Hospital. She was treated in New York. She ultimately wound up at Baptist Hospital in Memphis. And at that time, because of the number you showed, there was a very inadequate sharing of data across the various hospitals where these kinds of, in that case, non-malignant tumors existed. Has that been improved over the last 25 years?
So sharing of data is definitely better. HIPAA has put some restrictions on that, but I think if somebody is critically ill or there's, we need to get information, most physicians are comfortable with sharing that information. Ideally, we would all have that little chip in our arm that would say, this is the medicines I've taken, this is my history, this is my story. Hasn't been invented yet, but that would be nice. But we're trying to get better with, actually Partners is one of the leading institutions for electronic medical records, and so there's a shared medical record system for all of the Partners institutions, and so that has really helped us a lot in care of patients.
Who determines the protocol for how the money is spent? Let's say you got $50 million from the Gates Foundation. How would you spend it? Where would you start? What are the most important things? What is the priority on your mind?
So in my mind, I'd like to do, better genomic sequencing of tumors and really figuring out what the genetic changes are.
Genome is what?
So the DNA, that structure that makes up all of our cells and who we are. So I think if we can do genomic classification of tumors and really find out what the specific mutations are within an individual tumor, then we can find what we call the driver mutations. What is making that tumor grow and proliferate? And I think that would be a huge tool. We're starting to do that on a smaller level at MGH, so all of our cancer patients get doing genome-wide testing is very expensive. It's about $2,000 or $3,000 a sample. So what we've done at MGH is try to do a smaller sample of what are known driver mutations in tumors, ones that also have drugs that can target them. Because the first step is doing this genomic classification, figuring out what the abnormalities are in the tumor, but then you have to figure out drugs that will target those abnormalities. But you have to figure out what's wrong first.
So unlimited amounts of money.
Unlimited amounts of money, yes.
Would hasten the
right.
solving this issue, right?
Yes. Money makes everything move faster, right?
Following up on the money question, NIH funding has been flat to down, I believe. Can you give us a rough idea of, in your universe, where the money is coming from?
So most of our money, we have some NIH grants, but most of our money is coming through drug companies who sponsor clinical trials, and the downside to that is they often have control of the data and control of the design of the trial. It comes from other foundations that support cancer research, and through we have this brain tumor consortium. So some of the funding comes through the Brain Tumor Consortium, but those are the main ones. It tends to be a lot more foundations
helpful if you could just describe the different levels of trials so that people understand how to recognize a superior trial from an inferior one, and just some of the broad brushstrokes of what trials mean.
Sure. So there are different phases of clinical trials. There's phase 1, phase 2, phase 3. Phase 1 is the earliest stage of testing where we're trying to figure out whether, what is the dose of the drug that is tolerable in humans. Phase 2 is the next stage where we're trying to figure out if there's any signal with that drug in a particular type of tumor. And then phase 3 is the next step before FDA approval. And so when and those tend to be the larger multi-center randomized clinical trials. And so when you're looking at a good clinical trial, ideally it would be randomized, meaning that half of your patients get your study drug and half of your patients don't. And so you can really see if your study drug is helping patients. And so you want both the patients and the physician to be blinded to what the treatment is. So it's a completely unbiased study. But it has to be well controlled and well conducted.
So one thing I note is that breast cancer used to be a devastating disease. I mean, it still is a devastating disease, but it is now mildly curable, where like if you have breast cancer, it's not the death knell of I have a brain tumor, right? So there's treatments, there's options. You likely will live through breast cancer. It wasn't always like that. How do we make brain cancer like breast cancer? I mean, it can't just be we just throw money at it, and if we throw money at it, it'll work, because that obviously didn't work with breast cancer, because there wasn't always a Komen Foundation. There wasn't always all these supporters that gave money every year to breast cancer, because there weren't people that were alive that survived from breast cancer before. So what's the best way for us to make brain cancer more like breast cancer, where it's more treatable? It's something that if you get diagnosed with it, doesn't mean that it's a death knell. Like, how can we do that?
Right. It's a great question. I'm not sure I have all the answers, but I do think it is patient advocacy. So it is going to the NIH and saying you need to make this a priority. The NIH is very good for creating workshops and getting investigators together, getting people collaborating together, different researchers working together, pooling resources, because it really is a rare tumor compared to, say, breast cancer. So there has been a push in the brain cancer community to really try to set up more research collaborations across the country, and so we do participate in several networks like that. And so there has to be this sharing of data and resources to really advance the field. I do think that part of the reason that breast cancer, those strong advocacy groups really do drive the research and can fund the research, and that's ultimately how the breast cancer is really advancing. Breast cancer is also a very different disease. The brain is just such a privileged site. I mean, the brain is so much of who we are, and trying to get in there and get at the tumor itself is very difficult. So I think it's this increasing patient awareness, advocacy, and getting research to really collaborate together, I think, is very important.
Because brain cancer tends to be a relatively rare disease, and so much of research is driven by drug companies that are really looking for a revenue stream of a treatable disease that affects many of us. How do you circumvent that as a researcher, and what is the public's role in advocacy for change around the way that drugs are developed or treatments evolve?
So I think it's much harder to change the drug company philosophy, because they are much more focused on the breast cancers, the lung cancers, the colon cancers, and we are sort of the orphan disease. But I think it's working with the FDA and the NIH to put pressure on these drug companies, whatever power that they have, to really say you have to start expanding your avenue of drugs for other types of tumors, maybe making it an easier pathway if it's a rarer tumor for the drug company to not have to spend 10 years developing a drug, and sort of maybe shorten that approval process for drug companies if it's a rare, hard to treat tumor.
I asked this question because I really don't even know where you'd begin to start, because you talk about curing and solving and detecting, but is there any research, and where would you begin to, how do you begin to be preventative? What could obviously be done for any cancer, but brain cancer in particular?
So unfortunately, we're not there yet, and sort of figuring out what is that initial seed. But I think it is looking at sort of large population-based studies, and there are some of those that people participate in. The heart disease groups are very good at this and developing risk models for who's going to develop heart disease later on in life. And so maybe we have to start thinking about that, or use some of the data from the heart disease models to say who in that cohort of patients, yes, they were looking at development of heart disease, but is there anything that maybe predispose those patients to developing brain cancer later? It just ends up being smaller and smaller numbers of patients, and so making causal associations is challenging. But at least they're reliably collecting the data. They do survey data every year. Patients just fill out questionnaires, and then later on they'll develop their heart disease. But you can go back and look at those questionnaires that were collected in real time every year to figure out what might have triggered it. And I think if getting back to these biological underpinnings of the tumor, genetic underpinnings of the tumor, if we can understand what those mutations are, we'll have a better sense of what maybe caused those mutations, because we might understand that pathway that's abnormal as well.
Okay, thank you.
Thank you.